Hello and welcome to Jas-Health for the people by the experts, a public health awareness initiative by Jaslok Hospital. I'm Jitendra Harian, your host for the show. Today's episode unpacks endometriosis, a silent disruptor affecting millions of women. We explore its symptoms, challenges in diagnosis, and breakthrough treatments, aiming to raise awareness and empower listeners with expert insights and compassionate understanding. We have with us our expert, Dr. Abhishek Mangeshikar. Dr. Abhishek Mangeshikar is an expert excision surgeon and is dedicated to spread accurate awareness about endometriosis. Trained in advanced gynecologic endoscopy and minimally invasive surgery, he has performed nearly 3,000 procedures and led a multidisciplinary practice for over 10 years. His interests include bowel endometriosis, imaging AI, and neuropaleology. Dr. Abhishek advocates early diagnosis and expert treatment, aiming to unite stakeholders and revolutionize endometriosis care in India through education, innovation, and community collaboration. Welcome to Just Health, Dr. Abhishek.
Thank you for having me. It's a pleasure to be here.
Dr. Abhishek, we are now alerted quite a bit by this disease called endometriosis. Please tell us what is it?
Endometriosis is a very common disease. In fact, it's more common than diabetes. It affects approximately 1 out of 7 to 1 out of 10 women primarily, although there are 27 documented cases in males. It is a globally prevalent disease. It's not a disease of the affluent or of lower socioeconomic status. It disease that knows no race, caste, creed, or anything. It attacks, and it is an invisible ailment that kills quality of life. It is basically the presence of tissue that resembles the inner lining of the uterus called the endometrium. It bears similar characteristics. It's not the same thing that can grow literally anywhere in the body. It's not just a gynecological disease. It's not confined just to the pelvis and the pelvic organs. It can grow in the abdominal wall. It can grow in the bladder, in the diaphragm, in the chest. We've had cases where it's been reported in the wrist and
Okay,
rare cases in the eye and the brain as well.
I see. Do people still think the period pain is normal? Can you tell us why this belief is so dangerous?
Yes. This is a very dangerous belief that normalizing period pain because it starts from adolescence, which really delays the diagnosis. Now, any period pain that is debilitating, damaging quality of life, causing one to miss schoolwork, social activities, or sporting events is something that needs to be paid attention to. Any kind of pain that is outside the ordinary, requiring bed rest or even medications needs to be looked into rather than ignored. We've been trained in societies in India and globally that we see in the familial support systems that when a young woman complains of pain during her period, she's told that this is part of growing
Yeah.
up, it's part of becoming a woman, and
This
the
is quite
silly
normal.
myths. uh, the silly myths that getting pregnant will solve the problem and that really defers treatments or diagnosis, which is why there is a global diagnostic delay of 7 to 10 years on an average from the time someone presents with symptoms of endometriosis till the time it's actually diagnosed.
So if there is a pain, I'm sure the person should get diagnosed as early as possible. Could be the reason or the symptoms, one of the symptoms of endometriosis.
One of the common symptoms, it presents early. If there's pain, usually it does, if it's extraordinary pain requiring intervention or requiring a break from normal activity, interfering with quality of life, then that deserves specialist recognition.
Endometriosis is often described as a mystery disease, but from a surgical specialist perspective, what is it actually doing inside the human body?
Endometriosis is a very intriguing disease. It's a specialist disease trapped in a generalist specialization, which means that it is a disease that is more complex than most cancers, but it is treated by general gynecology, and there is a desperate need for a subspecialization in endometriosis. Whereas in the gynecological community, we're very quick to refer a case that has cancer. Whereas in endometriosis, there is an inertia to actually treat the disease. There is this thing where they start with denying it first, then treating with NSAIDs like paracetamol. And then eventually, when somebody actually has a positive diagnosis, then they're told to get pregnant. If the patient has come in with a problem of pain, the conversation is rerouted towards fertility. Now, this reeks of misogyny, which is very, you would never imagine this happening to a man.
So typically, which parts of the body it would impact or affect?
So endometriosis has three subtypes. The most common, what people who are aware of the disease would consider, would be the chocolate cyst, which is the ovarian cyst that forms, which is old blood, and it turns dark brown on degeneration. So it looks like chocolate. So that's the most commonly one diagnosed, and it's the most easily seen on imaging, on general imaging. So, but the problem is it never exists alone, and those other two things that come along with it are often misdiagnosed or underdiagnosed. So, there's peritoneal disease. Now, the peritoneum is a film that covers the entire abdomen and pelvis, and it can grow there. And then you have deep endometriosis, which are big nodules that can literally infiltrate anything. Then it's like weeds growing through concrete, and the more they grow, the more they damage the foundation and the structures below. So, when specialist care comes in, they treat all three types of endometriosis. Whereas when generalists treat endometriosis, it's basically just focusing on the chocolate cyst. And that's why when we looked at gynecological guidelines across the world, the recurrence rates are 50 to 80%. Whereas when they zoomed in on specialist centers, the recurrence rates of this disease dropped down to 5%.
Okay.
Overall, 5 to 10%. But this is because of the ability of the specialist to identify the disease better and to remove it more comprehensively.
So we spoke about period pain. What are the other symptoms that one could face?
So it's not just necessarily confined to in and around the period. It can be before, it can be after, it can be during. It can be during ovulation pain, but there's also pain associated with the organs it infiltrates. For example, if you have it in the rectum or the intestine, there can be constipation, there can be loose stools. Both of them can be present together. You can have bloating where they look like they're pregnant. If you have urinary symptoms, it can either be involving the bladder or the ureter, which is the tube that connects to the kidney. In very extreme cases, we have where the kidney gets damaged beyond recognition and then it has to be removed, which is very unfortunate for a young patient. We can also have it in the chest. So these patients present with lung collapses every monthly cycle, which can be very, very debilitating and confusing because even your chest physician may not be familiar with this kind of disease.
What about intestine? It also affects that
Yes,
area?
yes. Any part of the most common part of the intestine is the rectum, but it's lower down. But
Okay.
you also see it in the large intestine as well as the appendix is very commonly affected. So even myself being a gynecologist, I tend to do a lot more removal of the appendix than we are associated or trained to do.
So people are shocked, Dr. Abhishek, that this disease is so common. Despite that, it still remains invisible for most women, even in 2025. Why?
Coming back to one is because there's such a big diagnostic delay. What was primarily taught in medical colleges was just certain types of appearances of endometriosis and about the cysts. Imaging, again, if it's done in generalist settings by a general MRI or a general ultrasound, they will only look at the uterus and the ovaries. And if there is a chocolate cyst, they'll report about that. But other deep disease and peritoneal disease that is slightly larger may go missed on routine imaging. That's why there are specialist protocols for ultrasound and MRI for endometriosis that are slowly gaining popularity and also training courses for them.
So we've also heard that on an average, a woman who's facing, this particular disease sees about 5 to 10 doctors and undergoes multiple failed surgeries before they see a specialist like you. Why this happens?
Exactly. So coming back to it, this is a specialist disease tapped in a generalist kind of profession. We have the average patient who sees me has seen 5 to 10 doctors and already had 2 surgeries. I'm very fortunate if somebody's not had a surgery and they've had a diagnosis and they come in. It makes my life a lot easier. But that doesn't mean that we can't treat them even if they've had
Yeah.
surgeries before. The maximum number of surgeries I've seen on a patient is 16 surgeries before they've come in for care to us. The problem comes in where they would see first general OBGYN, where they would be prescribed birth control or told to get pregnant. Then, rather than treating the disease, they're pushed into IVF procedures, which exacerbates the disease by giving hormonal stimulation. And then, eventually, when that fails and they're unable to get pregnant and their pain is debilitating, then then they may undergo a certain surgery, but it's called fertility enhancing surgery, which they feel that they don't want to do too much. They just want to optimize the patient for getting pregnant via IVF. So that again leads to a series of misdiagnosis and undertreatments. And this is what happens to most patients. Whereas, most importantly, they need to be referred by the correct pathways to specialists so that they can have the appropriate treatment, and the surgery should be one and done. Don't need to go through revolving door surgeries year after year.
This leads to a question in my mind is that is this I can understand the lack of awareness among the patients. So is it also to do with the lack of awareness among the experts, as in the primary, doctors who are treating?
Exactly. That's perfectly well said. I think I couldn't have summarized it better myself. There is, of course, in the general population, a very limited knowledge about endometriosis, in spite of it being a very prevalent disease. And it's shameful to say that in the medical community as well, the awareness about this disease and the nuance that is required for it is quite lacking. Obviously, there is some awareness happening nowadays. There are very active patient advocate groups that spread correct information. There are doctors who put out correct information that is evidence based and what needs to be done for this. So there is a movement, but I don't know if it's too little too late, and it's probably not moving as quickly as it should.
Also, these patients, when they do MRIs, ultrasounds, they're often normal, and but the underlying fact is that there is endometriosis. So, how this is not even captured there?
That's so a normal ultrasound or a normal MRI does not rule out endometriosis. Now, with imaging improving so much, the area or the era of a diagnostic laparoscopy is almost dead. You don't put in a laparoscope to go and look for disease, but or even if you do it with the intention of treating it at the same time. That being said, it's not enough to have your general ultrasound or MRI in somewhere like the medical equivalent of Shoppers Stop, where a general radiologist who is just scanning everything. There are
And he'll
people
find,
who
he
are
won't find.
exactly. There are people who are trained to look for endometriosis, like at our center here at Jaslok. They do probably the most comprehensive MRI for endometriosis in the country, and the diagnostics are second to none. So I can read the report and the images from them and be exactly sure of what kind of procedure I'm going to perform. So I can finish the surgery in my head and have that conversation with the patient before she even makes it to the hospital operation theater.
So, how do you diagnose then?
So I've been trained to read the MRI myself and do the ultrasound myself, because obviously initially when I started my career, I was facing things at surgery that were not reported on imaging. And I said, why is this? So starting here, I worked very closely with the radiology department, and we had a lot of back and forth. And I would call them up after surgery and be like, okay, go back and look at the imaging. This is what I found during surgery that you all missed. And then we grew together and were able to improve upon what we were diagnosing and what we were treating as well.
So now we know if our radiologists are only who to catch.
Yes, we call them up immediately. I'm a very, very annoying person to deal with if something is wrong.
So, through this opportunity, Doctor, what are the common myths that you would want every woman to unlearn about endometriosis?
So, myth number one is that pregnancy or menopause cures this disease. This is a myth that still is perpetuated in gynecology, yet there is very little evidence to support this in medical literature. Myth number two is that removing the cyst is treating the disease. If you think about the disease, the cyst is like the tip of the iceberg, and the iceberg tip is 10% of the volume that's above the water, 90% is underneath. So if you don't treat the deep disease and you just remove the cyst, you're going to have a recurrence year upon year. Myth number three is that pain is equal to infertility, or rather, that endometriosis is equal to infertility. So that's not necessarily true. Only 30 to 40% of patients with this disease are infertile, and many of them primarily come in with complaints of pain of some kind. So 90 to 95% of them will have some kind of pain. So that should not mean that we're ignoring their pain and treating them only for fertility. Even they may not want to get pregnant, a lot of the conversation gets rerouted towards fertility. And there is a myth that endometriosis is a very chronic, recurrent disease, then it keeps coming back, so we shouldn't treat it. That's not necessarily true. In specialist hands, with good excision and removal of the disease, the recurrence rates are extremely low. So, repeating multiple surgeries is not usually done in specialist centers. It's usually one and done, and that's primarily what should be put out there in terms of myth busting for this.
Okay, excellent. So let's understand the impact of this disease on person's life. So, how does this affect the fertility and reproductive systems of women?
That's a very interesting take on from speaking from a fertility aspect of things. Endometriosis, the chocolate cysts themselves damage the egg quality. Secondly, it is a very inflammatory disease that creates adhesions in the pelvis. So, normally all the organs are separate from each other and they can move freely. This basically is like somebody throws a hand grenade in there and everything splatters and gets stuck together. So, it distorts the anatomy between the ovaries and the tubes and the uterus and the rectum, and everything kind of gets sucked towards one nidus or point. And that is basically how that distorts the anatomy. And if you change the anatomy, then the route for the egg to meet the sperm is kind of in chaos. Thirdly, the disease, like I said, is inflammatory. So it releases a lot of cytokines and things that are not favorable for pregnancy. So for the sperm to meet the egg, and even if there's an embryo form, for it to implant into the uterus, that is kind of hampered by this disease. So treating the disease is the first step. And even then, when IVF is done, this exacerbates in sorry, when IVF is done in the presence of inflammatory disease, it worsens the disease because you're super ovulating, you're giving
Yeah.
extra hormones. And two is it will make the disease worse because when you're going in through transvaginal ultrasound to retrieve eggs, you're creating more microadhesions between the ovary and the uterus. So that is, of course, we work very closely with the fertility teams and consider egg freezing in certain cases if they have access to the ovaries to preserve fertility because surgery also can damage the eggs if surgery is not done appropriately or due precautions are not taken. With the robot that we have, it does reduce the damage to the ovary compared to conventional laparoscopy. So that is a big blessing for patients who have fertility intentions with this disease.
So, you see a lot of patients getting pushed to IVF earlier, even without treating this, the root cause, the endometriosis. You see that often?
Absolutely, yeah, because a lot of general gynecologists or fertility specialists will ignore the disease and say, okay, we'll help you get pregnant. Of course, that's what their specialization is in. They're not necessarily trained to identify the disease completely, to understand that if it's growing in the bowel or if it's growing in the side wall where it's affecting the nerves, that doesn't come into play for them. So they focus on what their area of expertise is in, which is why it's very important that patients like these are dealt with in multidisciplinary centers where there's a meeting between different specialties and we discuss, okay, this is what the disease actually is. If you do an IVF protocol in this kind of disease, what are the outcomes? What is our success going to be? Should we do surgery first? Should we do IVF first? I'm not saying which one is right or which one is wrong, but that decision should be made jointly together for the patient's best interest.
Perfect. What is the psychological and emotional cost of living, with this unrecognized pain?
That's a very important thing to talk about, which is unfortunately not spoken about enough in terms of this thing. Now, a patient who's young and for years and years is not receiving answers, of course, that is going to take toll on her mental health, where she starts to doubt her own self. And especially in the adolescent years, those are the most susceptible group of patients that I see, where their peer group is breezing through starting their periods and they're not having any issues, whereas they feel like they are in the middle of a war when that period starts for them and they don't know what to do, and they go to doctors and they're told wait it out until they're older, or they've given painkillers which is not going to help much, and at some point they put on birth control which may suppress symptoms to an extent, but it's not treating the disease. So this is a huge problem affecting them on their mental health. And it's really what I've seen in my own practice is once they get that diagnosis, there's more tears of joy at actually thinking that it's not in their head, but it's actually in their pelvis. And I think that is a huge validation for them that, people for years have been telling them you're drug seeking, you're attention seeking, or it's not, there's no disease, all your scans are normal, there's something wrong with you, which is a very bad thing to happen to young patients and even older ones who've had these kind of things happen to them.
So, there must be a lot of toll on the professional and personal relationships in these cases.
Yeah, there's a huge BBC study in, I think, 2019, which looked at something like 40,000 patients with endometriosis. There was reported stunted career growth, stunted academic progress, it affected relationships. 50% had some self harm, 1% actually attempted suicide within that population group. And of course, if somebody is having pain with intercourse, which is something that's supposed to be enjoyable, and they're not able to function, they're not able to move, they're not able to exercise, that is going to play a tremendous role on somebody's health. It can deteriorate any relationship. To see your partner in pain is going to take its toll on the relationship, because you're helpless with what to do for them, and for whether it's a family member or a spouse, and you don't know what to do for that until you can get answers. And that obviously does have its toll on relationships, probably, um, which I think in the long term, I've seen a lot of partners being very supportive of their spouses as well when they come in for consults. They've done research about the disease and ask all the right questions. So I think that is a good, promising thing that I see in my practice.
Now, the important part, the treatment. So, we have heard that you emphasize on the full excision surgery and not just cyst removal or, burning spots. What's the difference?
Excision is removing the disease from the roots. So the idea of doing surgery for this is to treat it similar to how you would approach cancer surgery, where you would go wide until you are clear of the disease. If you leave something behind, it's very likely to recur. Treating only the cyst and leaving the rest of the disease behind is a recipe for disaster. And what was initially done, or what was taught in the 80s when laparoscopy came about, obviously they did not have the skill sets and the technology possibly to do these kind of surgeries until maybe the 90s, when they were taught to just burn the top of the disease. Now, the problem is when you look at a lesion, you don't know how deep it's going. So, what may appear to be very superficial on initial inspection can probably infiltrate all the way down to the nerves. So, now if you're burning just the top of it, you're leaving the rest of the disease behind. You're not getting a pathological diagnosis because you have nothing to biopsy from that. And eventually it does more harm than good, because when you burn something, it's drawing tissue together, so you're probably pulling more nerves into where the disease is, which is going to worsen the pain. So ablation or fulguration or coagulation of lesions is no longer done. There are exceptions for small cysts where you can coagulate them, because removing that cyst can damage the ovary, but again you would be very selective on what energy you're using. But I'm talking about lesions in general, where we prefer to excise and cut them out rather than burn them or incomplete treatment.
Which is why it also reduces the chance of recurrence.
Exactly. Huge,
Yeah.
huge statistical difference in terms
Yeah.
of recurrence.
Yeah. Doctor, at Jaslok, we see patients from all across the globe, including Middle East, UK, Canada, etc. Why are patients choosing India for most complex reoperations?
I think because endometriosis is a very widespread disease, we had estimated something like 250 million patients worldwide with this disease. In India itself, there's something like 45 million that are reported so far. And that's only what's been reported. It's probably a lot higher. Now, if you look at the global endometriosis community, there are about 300 surgeons in the world who do endometriosis. And out of those 300, there are about 40 or 50 who can do very advanced disease. So even if all of them work tirelessly, they wouldn't even be able to treat 10% of the patients. So that's why I think patients now, unfortunately, have to do their own research and due diligence to find out the specialists. And I think, obviously, because of the work that we do and recognition of how we've trained and we collaborate internationally, that these patients end up finding their way to India, where we're able to offer the kind of services and care that should be offered for this on an international level. So it's not longer that they're traveling to what is considered to be a developing nation, but in terms of care, we're probably at the top of the food chain when it comes to this disease.
You spoke about multidisciplinary approach. Please explain how it works in your case.
It's a very important part of the endometriosis care. So, multidisciplinary team had come about from the concepts of what we had created initially for ovarian cancers. So they found out that when ovarian cancers are treated in an MDT, the survival rates improved over 5 years. And with applying the same model to endometriosis, we see that it's not just a gynecological disease. So the gynecologist can say, okay, I'm going to treat the pelvic disease, but I can't treat the bowel disease, or I can't treat the bladder disease. So we have collaborations with urology. We have collaboration with colorectal or general surgery, thoracic surgery for when it's in the chest. Also, apart from surgical, there is teams with fertility to discuss fertility protocols and outcomes or egg freezing, and even with the radiology to help map the imaging beforehand. And then pain management, who helps us with other pain factors, and physiotherapy that helps with recovery. And also the mental health aspect of things. So we have counselors and psychologists and psychiatrists as well on board to help with managing every aspect of the disease so it can be treated holistically. It's not just a disease of one specialty.
So this enhances the overall safety of the patient and improves the outcomes as well.
Exactly. So safety is not just treating the disease, but treating the person.
So, Dr. Abhishek, would you like to talk about a challenging case, that left you flabbergasted?
I mean, as recent as last month, there was a recent write up about it. We had a patient who came in to Jaslok from the Congo. And it was a very interesting case because she had an open surgery where they do a midline laparotomy. And they did a peek and shriek where they opened and they saw what they did and they said, no way, we're not dealing with this. And they closed, which is a disaster. But then she came here and then we had seen her and we did the appropriate workup and realized that she had a huge endometriosis mass that was growing into the right side of her pelvis. So it had entrapped the ureter, which had caused kidney failure on the right side. It had grown into half the bladder, half the vagina, and down into the rectum. So it was almost as aggressive as cancer. And then you had this whole mass of tissue, which is normally very soft and free. And it was like cutting through cement. So we worked for 12 hours on this using a robot. So my urologist colleague started, he removed the kidney and left it in the pelvis. Then I started and mobilized the full pelvis and the disease down to the sciatic nerve. It resected half the bladder, mobilized the rectum, resected the bowel that was affected. And then my colorectal surgeon came in to help me join the bowel back together. And then the urologist came back to help repair the bladder. So very long surgery, but we got breaks because we worked as a team. So there was no compromise in surgeon fatigue. And also with the robot, that it allows us to view and kind of work together and basically optimize the outcomes. Now, this patient, normally, if some surgery like this was done, this patient would have ended up with a colostomy bag and possibly requiring long term catheterization. She had no colostomy bag. She was discharged in a week and she had her catheter out in 10 days and the stent removed a month later. So she's doing fantastically
So
well.
you explain again the role of the multidisciplinary team here. So, doctor, you built a global data registry. What are the outcomes compared to global averages?
So we are very good in terms of low recurrence rates. So the reoperation rates for patients are very low. We also have very good fertility outcomes. And usually, when you're doing advanced disease, the belief in gynecology is that you have to remove the uterus and the ovaries. Now, by definition, endometriosis exists outside the uterus. So there's no real justification to remove the uterus in the absence of any disease inside the uterus. Of course, with endometriosis, you can have adenomyosis or fibroids, which are inside the uterus. Then a hysterectomy becomes indicated, or you treat that. But if your patient is younger and desirous of fertility, treating the endometriosis involves treating the endometriosis, not removing an organ. It's like I tell many patients, if you have appendicitis and somebody tells you to remove your uterus, you'd think they were a fool. So the same principle applies. So we're able to improve fertility outcomes by a natural conception or whether ART is needed with the IVF team. And also that the pain scores are improved, the recurrence rates are lower, and I think patients are overall doing well. Of course, even I do have my fair share of reoperations, but those are usually for adenomyosis or a recurrent cyst at the most. Usually, when we're doing deep disease, that rarely tends to recur. More importantly, that over time, this disease is considered fraught with complications. That complication rate has gone down quite drastically. So ideally, when somebody starts out doing resections of the bowel, they do colostomies or ileostomies. We haven't had to do one in the last 2 or 3 years, and we end up doing probably more bowel endometriosis than probably the highest volumes in the whole continent of Asia. So I think that volume and experience itself has given us a great
Upper
improvement
age.
in reducing complication rates.
Okay. And how about the lack of awareness? How do we compare or with the others?
There is
Similar
not
or
similar. There's not
yeah?
that much of a structured support patient advocate group in India yet. I believe some patient advocates are working on it, and that's good. But they don't have as strong as a voice. But I work with ICMR and certain research institutes to study this. And there are a couple of scientists who are very active in this space about creating awareness and even establishing a nationwide registry for this disease to study certain aspects of it. And then eventually work towards studying our tissue samples and like a biobank to eventually work towards R&D to finding a cure that doesn't involve such massive surgeries.
What gives you hope? Is it technology, training, or research that the next 5 to 10 years will be transformative for this disease?
I hope so, because I think, like I said, the amount of surgeons that are there, and I do my best to train whoever is interested in learning this kind of surgery. I have fellows that come in internationally that train with me, and they can go back to their country and start replicating these models. That itself is a good thing to be able to give back and to teach. And I'm more looking forward to improvements in diagnostics. That's happening. There's AI coming in, which can map the disease probably a little easier for us. There's AI coming into robotic systems, which it can probably superimpose the radiological imaging onto your surgical picture, which will help you target the disease a lot better. There are some very interesting developments happening, so I'm looking forward to that. I like tech, and that
Yeah, and
is always
I
fun for
hope
me.
these numbers, and the awareness, lack of awareness comes down.
Try to organize some programs for that for our medical practitioners, but also for the patient populations. We've had support group
I'm
meetings for
sure this
them.
will help as well, at least for the patients. And if we need to do something for the GPs or the primary consultants, who are first looking at this patient, I think we must work towards that. I'm sure you must be doing something in that direction as well.
I do, and I think this is a great platform for that. Having a podcast, your reach is probably immeasurable, and that I think itself would do great to create awareness, not just about endometriosis, but about other diseases and specialties.
What should women do today if they suspect they might have endometriosis?
So, unfortunately, a lot of patients fall through the cracks where they're not given a diagnosis and they end up having to do their own research. So, if you suspect that you have endometriosis or someone close to you has this disease, then you can kind of look up specialists near you. There are various online resources on social media groups, which are a bit of a double edged sword, but there are some good groups that are very legit and have good resources. And I think that's the first step forward. Or you can ask your familial or medical support system who does this kind of specialization. Is this something I want to look into? Or if you're seeing your gynecologist, say, could I have endometriosis? Can you refer me to a specialist? And then that
Perfect. I
would
think
be
that
the
was
next
well
step
said.
forward.
Yeah. So, Dr. Abhishek, let's have some rapid fire questions. If endometriosis were a movie villain, who would it be?
So Thanos, it's the one that doesn't show up on the first 5 doctor visits, and then it needs a team of Avengers to
Perfect.
get rid of it perfectly.
Rename endometriosis to make it sound cooler. What would it be?
The chameleon, because it can mimic various conditions like IBS, UTIs, so urinary infections. It can mimic cancer sometimes and constipation. So it can mimic a variety of diseases and often gets misdiagnosed.
What's more unpredictable, endometriosis symptoms or Mumbai traffic?
Endometriosis is more unpredictable. At least Mumbai traffic still follows some semblance of rules. Endometriosis has no respect for rules, organs, disease, boundaries, nothing. It does whatever it wants to.
What's your favorite analogy to explain endometriosis to non medical folks like us?
There's a very important thing about endometriosis where I say if there is certain things trapped within the disease, it's like trying to separate your hair from chewing gum. You can't really pull the hair strands out, you probably have to cut through it. And that's exactly how it works. It's like weeds growing through concrete and then it's just ripping through the foundation. Every little bit it progresses.
What's your go to snack after a long surgery or consult?
Protein shake and lots of caffeine.
What's one myth about periods you wish would disappear forever?
That periods are okay to be painful. It's part of growing up, getting married, and having children will make it go away. There is no evidence to support this, and I wish people would stop saying that.
We know you're a passionate doctor, But what if Dr. Abhishek was not a doctor? Who would he be?
I'd be a lawyer because my favorite thing to do apart from medicine is to fight with insurance companies for women's rights. I keep saying they're the most misogynistic when it comes to women's healthcare, and anything that is short of removing the uterus is denied under fertility treatment. So that desperately needs to change.
Any message to the audience?
I would say, again, going back to the 5 myths about endometriosis, that painful periods are not normal, removing a cyst is not a treatment for the disease, and endometriosis does not necessarily mean just infertility. And we need to stop telling people to get pregnant or wait for menopause to find a cure.
Thank you, Dr. Abhishek, for demystifying this mystery disease endometriosis from symptoms, diagnosis to treatments. I'm sure this will spread much needed awareness among our audience to get identified and treated early. Thank you once again for your time.
Well, thank you for having me and for the opportunity to speak about this.
Excellent. Thank you.
Jas-Health for the people by the experts, an initiative by Jaslok Hospital.
Click the bell icon and subscribe to our YouTube channel to stay healthy and stay tuned to Jas-Health for the people by the experts, a public health awareness initiative by Jaslok Hospital.